Okay, well, good morning or good afternoon, good evening, wherever you are. My name is Lourdes Perezada. I am a dermatologist. I work at the Brigham and Women's Hospital, Harvard Medical School in Boston. And I'm very happy to welcome you to our new iteration of the GRAPPA Virtual Congress highlights. We're very excited to have you today to share the latest research that has been presented at a EULAR 2025 focused on psoriasis and psoriatic arthritis. This meeting recently happened in Barcelona, and I'm joined today by my co-moderator, Fabian Proft.
Yes, Lourdes, thank you so much. Yeah, it's a great pleasure to have another episode of the Virtual Congress highlights today. And today we will have 3 different presentations presented by brilliant young Grappians that were supervised when constructing their presentations by senior GRAPPA members, experts in the field. And we are really looking forward to the 3 topics: basic science, clinical topics, and newest treatments on PSA and psoriatic disease in general. And yes, as said, without any further ado, I think we can get started. Here are our disclosures without any influence on the current presentations today, because we only have the pleasure of moderating. And as said, we will start with the basic science highlights that are going to be presented by Hannah, and then we will have a Q&A. And for the Q&A, it's really important that you, as the audience, that you are asking the questions in the chat, and then we can direct them to the experts. And we will also have a panel discussion with the cross experts around the field. I'm really happy that we have such a distinguished faculty today. Yeah, and I think, Lourdes, we can get started.
Perfect. So we're going to start with the first session. I am delighted to introduce today to Hannah Johnson. She is a consultant rheumatologist in Forth Valley, Scotland, where she leads the psoriatic arthritis clinic. And she also holds an honorary lecturer position at the University of Glasgow, where she completed her PhD. Hannah wears many different hats at GRAPPA. She is very active. So she is the lead of the Young GRAPPA newsletter group. She's a member of the GRAPPA slide library team and one of the hosts of the Inside GRAPPA podcasts. Well, Hannah, we look forward to your insights on basic science abstracts from EULAR. Please go ahead whenever you're ready.
Thank you for the introduction, and let me just share my screen. There we go. So thank you. So I'm the young Grappian, and Andreas Ramming is the senior Grappian. And these are our disclosures. Rather than going into deep depths on the and details of a couple of abstracts, I've chosen 2 abstracts for each of these topics. So the first 2 abstracts relate to synovial research, and basically psoriatic arthritis synovium is not the same as rheumatoid arthritis synovium. It might seem like quite an obvious statement, but going back just a few years, there weren't really any definite features that could truly or definitely distinguish the 2. So the first abstract that I wanted to mention is this one, and to be honest, there's so much in this that I could spend the whole session talking about it, but rather than doing that, I'm just going to go into some of the key messages. So the background to this is that the macrophage-rich lining layer in active rheumatoid arthritis is populated by inflammatory dendritic cells that promote synovitis, and how they interact with the stromal compartment and that's driving this niche is not known. So, and don't worry, I'm not going to focus too much on the rheumatoid arthritis, but the collected rheumatoid arthritis synovial biopsy, and also almost as many psoriatic arthritis synovial biopsy, and also a few samples from traumatic injuries, which they used as controlled and did single cell sequencing. And then they went on to have 4 synovial samples for spatial transcriptomic analysis to look more. So that, of course, I'm sure you're already by now aware that the single cell sequencing looks at gene expression of all genes in individual cells, whereas the spatial transcriptomic analysis matches a less, not as deep transcriptomic analysis with a tissue location. So this slide is used a single cell sequencing analysis and then done complex analysis to work out which cells the dendritic cells interact with. And I think it's pretty obvious from this slide that dendritic cells in rheumatoid arthritis synovium interact with more types of cells than in the controls and psoriatic arthritis synovium. And I also would like to highlight that the cell types that the dendritic cells interact with is different in rheumatoid arthritis and psoriatic arthritis. The study then went on into do some really elegant analysis and showed the niche between these fibroblast macrophages and dendritic cells that was found in the RA synovium, but not in psoriatic arthritis. So the main take-home message for this purpose of this presentation is that within the inflamed synovium, there are less dendritic cell interactions in psoriatic arthritis than rheumatoid arthritis, and there are different cell types interact with the dendritic cells. And it's seen that we've got a session in the annual meeting on synovial biology, so I'm looking forward to that. Moving on to the second abstract, which also deals with the synovial biology, but comes from a different angle and more, I suppose, hypothesis driven, because recent studies have suggested differences in the role of autophagy in rheumatoid arthritis and psoriatic arthritis. And of course, autophagy is self-eating and a way of I suppose, for cells to clean up. So this study took synovial biopsies from 29 patients with psoriatic arthritis, 11 patients with rheumatoid arthritis, did H&E to do a Kren score, which is a way of measuring the severity of synovitis, and then did antibody staining for the autophagy proteins LAMP2A and ATG7, and looked at the density of the staining cells and did a logistic regression analysis to see if could use these markers to distinguish between rheumatoid and PSA synovium. They did a number of other cell markers as well, but I'm not going to go into that. But I've highlighted the ATG7 and LAMP2A on this slide. The top row is mild PSA, second one mild RA, third one higher Kren score PSA, and the lowest one high Kren score rheumatoid arthritis. And I think you can see that there is stronger staining for both of these autophagy markers in rheumatoid arthritis than in psoriatic arthritis, and it was particularly in the inflammatory infiltrate and this was seen. With the logistic regression, they then found that using the density, you could distinguish between rheumatoid and psoriatic arthritis synovium. So the take home from this abstract is that the density of cells expressing these autophagy markers appear to differentiate between PSA and RA. I suppose the next question then would be, will that perform any better than ACPA antibodies? And also maybe for the discussion could be, when would people consider synovial biopsies to distinguish between the two? So that has kind of ended the synovial section on biomarkers. So moving on to now with biomarkers and treatment response. So the first abstract looked at the proteomic biomarkers in patients who started TNF inhibitors, and they used the 50% DAPSA improvement at 6 months to define responder and non-responder. They did a proteomic analysis on peripheral blood mononuclear cells and used machine learning to identify proteins linked to response, and then a subset of patients, they've had samples for longitudinal to look more into the biology of what happens in responders and non-responders. So they had 74 participants in the biomarker discovery phase and identified 8 discriminatory proteins, and with a 2-protein model, it reached an area under the curve of 0.8 who's going to respond and who's not. And I should say they don't tell us which the proteins, discriminatory proteins are. And in the 20 patients they looked at longitudinally, there were upregulated proteins over time, or including B-cell pathways, and downregulated proteins related to neutrophil pathways. And the most significantly changed protein was CD200, which is one released by B cells and related to regulated neutrophil regulation. And it was increase in responders only. And they also looked at the full blood count and found an increase in lymphocytes and reduction in neutrophils. So it kind of fits together. The second sort of treatment biomarker abstract looked at patients starting secukinumab and used the UK-based ALPA study rather than a PBMC protein. They looked at whole blood RNA, and they had longitudinal samples for all of the participants. They didn't have a binary responder and non-responder, and so didn't include all participants, but I suppose enriched for extreme responders and also non-responders as per these definitions. So the sample size was quite small, 13 in total, with 7 responders and 6 non-responders. As I suppose expected, there were plenty of differentially expressed gene. Many of them were consistent, both at the baseline and 3 months, and amongst the responders versus non-responders, in the sort of top most upregulated genes are listed here, and I'd like to point out that a couple of them are immunoglobulin genes. And looking into when they did the pathway analysis of these upregulated genes, they were, for example, enrichments in communication between innate and adaptive immune system. They did upstream regulator analysis, including, for example, BET, which is involved in the development and function of a T helper cell. And when they looked at the most significant change in gene expression over time, they were linked to cell signaling, immune regulation, and inflammation. So take-home messages from these 2 biomarker to advanced therapies abstract is that transcriptomic and proteomic analyses seem to be able to differentiate between responders and non-responders. But a big but is that validation is needed before this can be put into clinical practice. As well as, hopefully one day we'll have a biomarker to predict response, so we know who to give what treatment to. I think these analyses, and particularly the longitudinal one, can help us to understand the pathophysiology and the biology of response and non-response. And I suppose one thing that caught my eye with these is, what is this thing about the B cells and immunoglobulins when we generally consider psoriasis, psoriatic arthritis as a T-cell mediated disease. But hopefully that's something that be researched in the future. So moving on to my last 2 abstract, and I put that under the heading of clinical hot topics. First one is regarding transition from psoriasis to psoriatic arthritis. This study did T-cell profiling in patients with psoriasis with at least 1 risk factor, prodromal PSA or established PSA, and did machine learning to identify key phenotypes. And there was a lot of data presented in this abstract, but the sort of headline would be that there were overlapping T-cell subsets in patients with psoriasis and prodromal PSA. There were a shift in some T-cell subpopulation, and in particular the CCR5, CCR6 cells with upregulation in the prodromal phase, and then a reduction in patients who had to develop psoriatic arthritis. And CCR6 is a marker of IL-17 producing cells. So take home from this one is that there is a shift in T cell endotypes in the transition from psoriasis to psoriatic arthritis. Okay, final basic science abstract now, and the hot topic this relates to is comorbidity, and in particular metabolic disease. And we know that metabolic liver disease is prevalent in our patient population, and also that apremilast has both anti-inflammatory and metabolic effects. And this abstract used a mouse model of metabolic liver disease to study the effect, the liver and metabolic effects on of apremilast. And they use this high fat, high fructose, high cholesterol diet. And then once they had induced the liver disease, they treated them with apremilast. So patients who were fed this diet did develop a metabolic liver disease type phenotype. When they looked at protein, there no surprise, there were altered proteins tied to inflammation, apoptosis, and lipid and chemokine signaling, and they were found across tissues. Apremilast reduced the body weight and fat mass, to be honest, both in the GAN mice and in the mice fed normal diet, but it was more pronounced in the mice with liver disease. And apremilast also improved I suppose metabolic liver disease markers like ALT and triglycerides and insulin. And there was also modulation of inflammatory proteins, fibrosis markers, and oxidative stress proteins. So the final take-home message is that apremilast may be beneficial in metabolic liver disease. So thank you for listening, and we'll welcome questions and discussion.
Yes, thank you so much, Hannah, for the perfect wrap-up from the highlights about basic science from EULAR. And now we can kindly invite all of you to ask your questions in the Q&A function of Zoom, and also invite Andreas as the senior GRAPPA member who supervised Hannah in constructing this presentation on the stage, and everyone from the panel also, if you have any questions. But please feel free to ask your questions about any of the abstracts presented in the chat function. And maybe I can start and invite Andreas to contribute with his perspective on the hot topics and the presented abstracts. Andreas.
Yeah, thank you, Fabian. I think it's very interesting to see that molecular diagnostics, and in particular sequencing technologies, gives us currently complete new insights into differences between the different disease entities. And as Hannah mentioned that very clearly in her presentation, I think this is a nice opportunity for us in the future to use these tools and to use these insights to better, first of all, characterize our different disease entities. Probably it will help us a lot also in the right diagnosis, and then of course later on also to develop new drugs, new treatment strategies to be more specific as we currently do. I think now a first question comes up in the chat. Fabian, is it true or?
Yes, there's one question. Maybe I can also just start with another question, because I think this is really be a bit speculative, but Hannah, what do you think? Based on the results, do you think that we will be closer to somewhat a precision medicine approach, that we can use synovial biopsies to predict treatment response and give one treatment to the one patient and the other treatment to the other patient based on the different results of the synovial biopsies?
I think at the moment we do not have the data on synovial biopsy and treatment response in psoriatic arthritis. There obviously have been some studies in rheumatoid arthritis looking at that, and I suppose they haven't been as conclusive as we maybe would have hoped they would have been. I suppose based on the abstract at EULAR, it does look like maybe there are soluble biomarkers that can help us to predict treatment response, but we are far from there. But I mean, it's the hope, isn't it? I mean, because I was looking at when I wrote my thesis 4 years ago, and what was known about synovial biology then, and I had written about more tortoise vessels, blood vessels in psoriatic arthritis compared to rheumatoid arthritis, and more mast cells in this and more of those type of macrophages. But that, so compared to where we are now to 4 or 5 years ago, it's moved for the knowledge about synovial biopsies have moved forward in leaps and bounds. And I mean, I'd anticipate that there continue to be a lot of work. And I mean, there are lots of group and for example, ultrasound guided synovial biopsies, I think, are getting done more commonly. The single cell technologies are more accessible and used, and more of a sort of ability to I suppose with machine learning and the analytics as well.
Yeah, great. Any further questions from the audience to this basic part?
I have a question. Had my hand raised. So there was one of your abstracts in which you showed that there was a biomarker discovery study, and they presented a model with 2 proteins with very good parameters, right, in terms of AUC and so on. But you mentioned that they do not say which those 2 proteins are. Can you comment on that and what it means to the field, and what do you think is going to happen with that?
My guess is that they don't want to disclose it yet, and that they are working on validating it so that they can maybe develop something. Would be my guess, but I don't know. But I think that would be my, maybe they don't want someone to scoop them.
It's there, but they don't tell, because then they do provide them this CD200, right? To differentiate responders from non-responders. Did I understand that correctly?
Yeah.
Or that they identify that there is a change in that one pre and post treatment, I think, right?
Yeah. So it goes up in responders, but not in non-responders.
Okay. And then related to that, do you know, is this the first study documenting the CD200, you said that they need more validation for this one, but are there other studies reporting on this marker, or is this like the first that we are aware of?
I have not come across it before. I don't know, Andreas, have you come across?
We studied in Erlangen this molecule, and we found this on fibroblasts in particular, and we identified that as a very interesting axis to induce resolution of inflammation. So it activates via CD200 receptor different cell types, innate lymphoid cells type 2, for example, but also regulatory T cells and eosinophils, and all those cells together then can further induce then this whole mechanism of resolution. I think this is the main mechanism. Belongs to the checkpoint signaling pathways, and I think that could be quite interesting for the future.
Okay.
But just to clarify, still, it's rather preliminary results that need to be validated in larger cohorts and different cohorts, right, Andreas?
Yeah, well, I mean, it was clearly shown in different mouse models that it has a significant impact, and also in biopsy-related human studies. So you are right that this needs further evaluation, but I think we have already quite strong hints that might be indeed a target for the future.
Perfect.
So one major concern and challenge in this kind of studies is to mention if patients were exposed to pre-treatment or not, because this can really change the result of your investigations. And we could end up with a set for patients who are, for example, pre-treated with methotrexate or with some other drugs. And very, very often people fail to mention if the patients were pre-treated or not. And that's really an essential condition, because we know this from hematology and oncology that the sequence of treatments can influence the expression of some of the biomarkers.
Now, this is, I think, very, very true, and this has to be precisely controlled in further studies, also included.
There's also still one other question coming through the chat. Hello, thanks for the great presentation. Were the ML-based models published, and which databases were used for their training and validation? Do you know that, Hannah?
No and no. Sorry.
Exactly the same for me, and I think it has not been published yet.
I don't think I've seen it, no.
Yes, to the best of my knowledge, but I don't know which databases were used for the training and validation. Thanks for your question. Okay, so I think we are perfectly on time and can move on. And thank you again, Hannah, for the perfect presentation, and also Andreas for supervising, contributing with your perspective. And so let's move on to the next topic. And really excited to hear about the new treatment models that were presented and discussed at EULAR. And it will be presented by Andre. Andre, very familiar to all of us here in the GRAPPA community, currently chairing Young GRAPPA, a brilliant mind in the field who is really contributing to GRAPPA and GRAPPA's mission. And Andre was supervised by Laure. And yeah, Andre, the stage is yours. Really looking forward to your presentation and then intensified discussions afterwards.
Thank you for the introduction, Fabian, and for the opportunity to be here. So, as I said, this presentation was developed by me in collaboration with Laura Gossek, and we'll now go over some of the most relevant treatment updates from EULAR 2025. These are our disclosures, which have not influenced the selection of these abstracts. Here's the outline for the presentation. So we will start with 3 promising agents with new data presented at EULAR, and then move to strategy trials, which evaluate treatment sequencing and early intensive therapy. So let's start with deucravacitinib, which is the first oral TYK2 inhibitor to reach phase 3 trials in PSA, the POETYK 1 and 2, that were presented at EULAR. So POETYK PSA-1 was a multi-center phase 3 randomized double-blind and placebo-controlled study evaluating deucravacitinib in patients with active PSA, including only BDMARD naive patients. These patients were randomized to receive deucravacitinib 6 mg once daily versus placebo, with the primary endpoint of ACR20 at week 16. The POETYK PSA-2 had a very similar design, but with a longer follow-up up to week 52. It also included BDMARD naive and experienced patients, although only 20.5% had prior biologic exposure. And as an additional difference, it had an extra arm of apremilast as a safety reference. Now going to the results. Here we can see the main outcome for POETYK PSA-1 with the ACR response at week 16, showing that deucravacitinib achieved an ACR20 in 54% of patients versus 34% in the placebo group. And in the other 2 graphs, we can also see higher ACR50 and 70 rates at week 16. Secondary endpoints like PASI 75 and MDA were also met at POETYK PSA-1. Moving from the PSA-1 to PSA-2, here we have the ACR response up to week 52, showing that ACR20, 50, and 70 responses continued to improve up to weeks 24 to 28, when they stabilize and then persist up to week 52, where we have an ACR20 response around 65%, in addition to significant ACR50 and 70 responses of 40% and 26%, respectively. Here we have the breakdown of secondary outcomes for POETIC PSA2, showing similar trends of continued improvements up to week 24-28 in PASI 75 and MDA, then a sustained response up to week 52. And finally, here we have the safety data at week 52 with no new safety signals when compared to the phase 2 studies and to the psoriasis studies, meaning that the drug was well tolerated with low rates of serious adverse events, including no increase in zoster infection. And the most common adverse events were mild upper respiratory infections and some cutaneous side effects. So to summarize, the deucravacitinib met its primary and key secondary endpoints in both studies. It offered a sustained joint and skin efficacy up to week 52 with a favorable safety profile. And as the first TYK2 inhibitor with phase 3 PSA data, it introduces a potential new oral option for PSA patients. Next, we move to zasocitinib, another oral TYK2 inhibitor currently under investigation. What makes zasocitinib particularly different from deucravacitinib is its highly selective mechanism of action. It binds to TYK2 pseudokinase domain, similar to deucravacitinib, but with roughly a million-fold selectivity over JAK1, compared to about 87-fold with deucravacitinib. And it also maintains a TYK2 inhibition above IC50 for 24 hours compared to 3 hours. And this higher selectivity and daily target coverage raises the obvious questions if this superior pharmacological profile would then translate to better clinical efficacy. So this was a randomized, double-blind, placebo-controlled, dose-ranging phase 2b study where patients received zasocitinib 5, 15, and 30 milligram or placebo for 12 weeks. It included active PSA patients with ACR responses being the primary endpoint. On the left, we can see the ACR responses 20, 50, and 70 at week 12, meeting the primary outcome, particularly with the 30 milligram dose. On the right, we can see the MDA achievement compared to placebo, where we can also see a dose response with stronger responses seen with 15 and 30 milligram. Skin responses were also dose dependent, with an even stronger dose dependency response in PASI when compared to the ACR responses. And here we can see that the PASI 75 response at week 12 was 45% to the 30 milligram group and 37% for PASI 90, also in the 30 milligram group. So as take home, zasocitinib appears to be a promising TYK2 inhibitor with higher selectivity and encouraging clinical responses in this phase 2b study. That said, these are still phase 2 data, and we do need phase 3 trials to see if this improved pharmacological profile will indeed translate into superior efficacy when compared to deucravacitinib, which this phase 2 trial did not show yet. So now changing to another mechanism, sonelokimab, which is a novel nanobody that selectively inhibits both IL-17A and F, similar to bimekizumab, but with the notable difference of its size being much smaller than bimekizumab, which might offer better tissue penetration and potentially enhanced efficacy. Also raising the similar question that we had with zasocitinib, if this different molecular profile now being smaller than the other biologics will indeed translate into greater clinical benefit. The ARGO trial is a phase 2b randomized placebo-controlled study that assessed multiple doses of sonelokimab in patients with PSA, also comparing protocols with and without induction, and with a reference arm composed of adalimumab. The main outcomes were assessed at week 24. The enrolled population had active disease. We can see a PASI roughly of 7%, and also had significant MSK symptoms. Concomitant methotrexate was used in most patients, roughly 70%. Here we see the ACR50 response at week 24, which were quite robust across all those groups. These results are encouraging for joint outcomes, with an ACR50 at week 12 of roughly 45%, and at week 24 of roughly 60%. Here we see the MDA response. So MDA was also achieved in a substantial proportion of patients, with both the 60 and 120 milligram doses, achieving up to 62.2% in one of the groups at week 24. And we can also see that the responses continue to improve over time in these initial 6 months of therapy. Finally, we have the joint skin composite outcome, where they assessed the composite of ACR50 plus PASI 100 and ACR70 plus PASI 100 at week 24. For ACR50 plus PASI 100, we could find a 51.9% of these patients meeting this composite outcome. And even for the most strict outcome of ACR70 plus PASI 100, which is a very stringent outcome, we could see that 48% of patients in the sonelokimab 120 milligram met this outcome. Regarding safety, sonelokimab was well tolerated with no major safety concerns reported, meaning that the nanobody format does not seem to introduce unexpected risks compared to traditional IL-17 inhibitors, and as expected, candida infections were more common in the sonelokimab group. So in summary, sonelokimab appears to be a promising dual IL-17 and A inhibitor with strong efficacy across domain, including joint, skin, and the composite of joint and skin. And the nanobody format may offer some pharmacological advantages, and phase 3 trials will be important to confirm these findings, which again are from phase 2 study, and really assess if there's a difference between typical biological DMARDs and nanobodies. Now we will briefly review 3 strategy trials, starting with the STEMP study. The STEMP trial is a randomized, open-label, treat-target study that tested early secukinumab-based therapy versus standard of care in patients with very early PSA, meaning patients diagnosed within 3 months, DMARD naive, and with at least 2 swollen joints. The early intensive arm used secukinumab 300 milligrams plus methotrexate 15 and a single dose of steroid up front, compared to the standard of care, which started with methotrexate 25 plus steroids, escalating the treatment only if needed. At week 12, the early secukinumab group showed significantly greater response, with an ACR50 that nearly doubled, 38 versus 17%, and there were better MDA and PASI 90 rates. However, by week 24, these differences diminished, and became very close. So while early secukinumab provided faster disease control by week 12, at week 24, this superiority was lost. The second trial is the GO-MEET PSA, which is a 52-week double-blind, randomized placebo-controlled study in early treatment-naive PSA patients designed to test whether early combination of golimumab with methotrexate plus steroids would outperform the typical standard of care treatment of methotrexate plus steroids alone. Importantly, in this study, at week 24, the biologic golimumab was stopped. So at week 12, there was a numerical advantage in PASDAS for the golimumab arm, but this numerical advantage was not statistically significant and also disappeared by weeks 24 and 52. However, it's important to say that even though the difference in the golimumab disappeared over time, one key point is that the patients in this group needed less rescue corticosteroids over time. So in the golimumab group was using 20% as rescue therapy, whereas in the standard of care group, it was using 50% of these patients. But then again, overall, no long-term benefit was demonstrated at week 52 in the early golimumab group. The last one of them, the SPEED trial, was slightly different because it specifically addressed a patient population with early PSA and at least one poor prognostic factor, like polyarthritis, elevated CRP, high HAC, or erosive disease at enrollment. Patients were randomized to one of three strategies: standard step up with methotrexate on the top, combination of conventional DMARDs from the start, or early TNF inhibitor therapy with adalimumab for 24 weeks in addition to methotrexate. And it's important to emphasize that just like the previous study, the TNF inhibitor, the adalimumab, was withdrawn after 24 weeks, which allowed for the assessment of early induction with the escalation strategy. So at week 24, both the early TNFi and combination of two conventional DMARDs achieved significantly better PASDAS score compared to standard of care, showing faster and deeper responses. However, by week 48, only the group that started with early TNFi maintained this advantage. So unlike the STAMP and GOMI PSA, the SPEED trial showed that in patients with poor prognosis, early intensive therapy for 24 weeks led to better disease control at week 48, suggesting reinforcing the idea that patient selection is a key factor for selecting our therapy and that we need to individualize treatments more. So to summarize the strategy trials, across the board, early intensive therapy, either with biologics or combination of DMARDs, led to faster disease control in patients with this diagnosis of early PSA. But when we looked at sustained benefit, only the SPEED trial showed long-term outcomes favoring the early biologic use, likely because it specifically enrolled patients with poor prognostic features. So for me, the key takeaway is that patient selection matters. And in those with more aggressive PSA, we might go to early interventions biologics in the future. However, still need to look in if this early benefit holds with a longer follow-up. And that's all for today. So thank you for your attention.
That was wonderful. Thank you so much, Andre. So now we're going to invite Laura Gosek. She's a professor of rheumatology at Sorbonne University, and she specializes in the care of patients with inflammatory arthritis. She's involved in teaching and a lot of outcomes measures research. So thank you, Laura, for helping Andre with this presentation. And if you have any reflection comments that you want to bring up now while we wait for questions to come in.
Yes, thank you very much, Lourdes. And it was really a pleasure to prepare this with Andre. I mean, Andre did all the heavy lifting here, but I think, yeah, it was a very interesting Congress. Of course, we had to choose with Andre a really limited presentation on treatment results. Any of you who went to the Congress saw that there's a lot going on in treatments of PSA, and we had lots on existing drugs, but we chose to focus mainly on the new drugs, which will be coming soon. So basically, as Andre said, there's only one drug where we had results from a phase 3 trial, and that was the deucravacitinib. It was a late-breaking abstract. So this is a drug which should come quite soon on the market. It's already used in skin psoriasis, and actually it's used quite widely for skin psoriasis, mainly because it's an oral drug. It has really good safety. So that might be an option for us to think about. I think the results in terms of efficacy were good. And Andre, you didn't have the time to really discuss the radiographic progression data, but there was data showing that it seems to inhibit radiographic progression already at 16 weeks, which is pretty difficult to show. So I think it's a true disease-modifying drug, if I can say so, compared, for example, to apremilast, where we never had those data for radiographic progression. And then Andre discussed with you two phase 2 data, which I think are both very interesting drugs, asocitinib, as you said, Andre, and then sonelokimab. Sonelokimab is really interesting in the pathophysiological way it works, because it's really a nanobody. It's the first time we're seeing data for a nanobody, in this case, inhibiting IL-17A and F. And I thought the results were very good. I mean, you did say this, Andre, but 48% of patients in this phase 2 trial, it's small sample size, reach ACR 70 plus PASI 100. Let's just reflect on that for a second. You know, when you're on ACR 70 plus PASI 100, you're basically doing really well. So, you know, that's, I think, very good. There's a lot that we didn't have time to discuss with you. A lot of data about the drugs we already have. Currently, TNF inhibitors are still widely used in PSA. I don't know for everyone on this platform and who will watch it as a replay, how many patients are being treated with TNF inhibitors as first-line biologic in your country. But in France, it's more than 50% who are getting a TNF inhibitor as first line. And of course, we who are PSA experts, we all know that there are other drugs which just work better for the skin. They just do. But then there's also the cost of biosimilars to look at, and also probably the long-term efficacy to look at. So that's something. Of course, lots of data also on IL-17 inhibitors. I mean, bimekizumab has really made a breakthrough, I think, in terms of the way it's being used now. And also a lot of data on IL-23 inhibitors. And I'd just like to very briefly discuss the APEX trial, which is, I think, very courageous of the guselkumab producers to do this trial. 1,000 patients, BDMARD naive, with at least 2 erosions. I mean, how many of those do we see? They managed to include those 1,000 patients, a mean disease duration of 7 years, and they show that there is radiographic progression with guselkumab, which is data we had a bit of a conflicting results on according to the dose of the drug. And in this high-risk population, both doses of guselkumab led to very deep radiographic inhibition, with a mean progression of 0.3 points, which is really low. So, you know, more data there to think about as we move forward. And then I think the strategy trials, we still need more work. So, dear colleagues, please go ahead and do strategy trials. We're so lucky we have Laura Coates working on this and giving us results at every Congress. But as Andre showed you, I think currently we don't yet know exactly what's the best algorithm for our patients. We haven't reached personalized medicine in that regard. And I still find that saying that treating early with biologics is better, I feel a bit uncomfortable with this. I don't feel we fully answered that question yet. And in fact, in many countries, that's not allowed for many of us to give a biologic straight up. So, but still very interesting results there. And I'll stop here and pass it over to Fabian.
Thank you. Yes, Fabian, go ahead.
And sorry, and just to say, Andre, congratulations. Wonderful job. I mean, there were hundreds of abstracts at this Congress on PSA treatment, and you did such a wonderful job presenting it in such a summarized way.
Yes, absolutely. I can only congratulate you as well, Andre. Perfect presentation. I really like the strategy trials because I think these really give us new insights, and especially because this really was something very new. Many of the other data we have already seen at ACR already had an idea about. Maybe I could invite Chris with your patient perspective also on, do you have any specific questions, or what is your take on the data presented?
So thank you, Fabian. I was going to raise my hand, and Andre, I completely agree. Great summary of key aspects. My mind goes to different things. Very excited about the new therapies. I think we all want new therapies and new options. I know we don't always have the luxury of getting those, but the advancement, I think, really makes a difference for patients. And I wanted to applaud the agent that was looking at the combined composite outcome should be a standard where companies are willing to go in and look at those composites and what that looks like for a high response for patients. I'm not sure, the ACR 20 scores don't really excite me as a patient because I'm not sure that that's really what I want. But what I did want to ask was the question, do we think, looking at these strategy trials, the response rates for methotrexate are horrible? I mean, horrible maybe is a little, hard, but from a patient, the response rates weren't very good with methotrexate alone. It's a burdensome drug for patients. And I think sometimes we forget about what that's like because it's the only option given. Is it time for us to be able to move away from methotrexate alone as a starting therapy, as a community, and help our patients at least get onto a combination therapy or find other treatment options? And I put that out there because it's widely used, but I think the side effects and burden for patients sometimes with methotrexate aren't always discussed, and because it's just expected that you have to try this. Do we have to?
And
I'm being
I
a little
think
provocative, but yeah.
Maybe I'll take that instead of Andre, right? Because I think it's a difficult question for Andre to answer based on the Congress results. I think, Chris, you're pointing out something many people agree on, that methotrexate, the balance of efficacy, safety, is not so good, especially from the patient perspective. If we look at cohort data, we can see that the maintenance of this drug is actually not bad in PSA, which either says that no one is willing to change or that the balance of overall efficacy to safety is not that bad. Of course, we also need to look at costs. We need to look also at access to drugs, and we also need to look at long-term use. So I guess you're asking a really wide question here, but really, Andre, the strategy trials that you showed all went in the same direction, that at least in the patient populations included in those trials, it looked like treating early with more efficacious drugs was good for patients, right? So I think, Chris, we probably won't be able to solve that in this conference, but
I'm sure.
Point you're making.
And two things that I also wanted to add on this. First, methotrexate 25 milligrams weekly is quite a high dosage from my perspective as well, to be used and also associated with side effects potentially. And I think what is really important when you look at the treatment recommendations, GRAPPA, EULAR, there are some criteria for high disease burden whatsoever that you can directly start us with a biologic, and especially also when looking for the dermatological colleagues, where you have the upgrade criteria. If you have significant skin disease, if you have high disease burden, you can go directly, also at least from the recommendations, go directly on a biological DMARD. And I think this is something that we need to better know in which patients we have to, and in which patients it's still okayish to start with methotrexate because the results might be positive in the short term and long term run.
I agree with Laura and Fabian. I think the key is really the understanding better how to select patients for starting with methotrexate or starting with biologics or starting with both. Because for me, the key conclusion after reading those 3 strategy trials, that we need to learn how to select our patients better and how to individualize therapy better. So for me, that's a take home for after reading those 3 studies.
I think what I would really like to see would be strategy trials where we're able to do adaptive therapy. So start with a drug, but if it doesn't work, and that's already what we have seen in some of the strategy trials you have, Andre, but they're not really personalized, meaning that you just get randomized one arm or the other. Whereas what we would like to do is integrate some elements about the prognosis, the personalized prognosis, but we'll get there. We'll get there.
Wonderful. Well, thank you so much, Andre and Laura, for this wonderful presentation of the treatment of abstracts focused on treatment in psoriatic disease. And now we're going to transition to our last session on clinical topics. So now I am pleased to welcome Daniela Tovar. She's a rheumatologist based in Lima, Peru. She practices there at the Rheuma Medic Center and Clínica Padre Luis Tesa. She's another active member at GRAPPA. So she's a young GRAPPA member and also a member of PANLAR Joven. She's involved in PANLAR studies for psoriatic arthritis and spondyloarthritis. And she also serves as social media editor of the Journal of Clinical Rheumatology and coordinates PANLAR Joven. PANLAR Mujer initiative. So now I'm doing English and Spanish at the same time, and it's difficult. So Daniela, welcome, and we're excited to listen to your presentation. Please go ahead whenever you're ready.
Thank you, Lourdes, for the kind introduction. I would also like to thank Dr. Kurt for his support in selecting the abstracts we will discuss today. These are our conflicts of interest. Today I will highlight 6 EULAR 2025 abstracts that provide fresh perspectives of the early detection, clinical features, and management of PSA, from risk prediction in psoriasis to defining complex and difficult to treat cases. One of the most discussed topics at the Congress was predicting the transition from psoriasis to PSA. And this study called Predicting Psoriasis Arthritis in the Onset of Psoriasis had 3 objectives: develop predictive models to guide early rheumatology referral, to build a prognostic model for PSA development in patients with subclinical PSA, and to identify predictors for PSA. The researchers analyzed data from the Stockholm psoriasis inception cohorts, which followed 672 patients with new onset psoriasis over around 9 patient years. Of these, 29% of them developed PSA. For the referral model, all patients were included in the analysis, and the resulting decision tree, as you can see here, stratified patients into 5 groups based on joint pain, pain in the past year, HLA-B27, and CRP. Those with no pain at all had the lowest risk, as you can see in node 3, around 5% of risk to develop PSA. And those with current joint pain and HLA-B27 positivity had the highest risk, around 80%. The model demonstrated a good performance with an area under the curve over 0.8. And for the subclinical model, they examined 138 patients who underwent for a rheumatological exam and were free of PSA at baseline. And they identified 8 predictors. The 4 most critical were HLA-B27 positivity, history of uveitis, axial intestinal pain, and peripheral intestinal pain. Again, the model showed a good performance. And finally, to identify predictors of PSA, the study analyzed patients without arthritis at baseline, and they found 24 variables that were significantly associated with PSA development, including arthralgia, fatigue, elevated inflammatory markers, and lipid abnormalities, highlighting the systemic nature of the disease. HLA-B27 also showed that increased the risk, while HLA-CW6 appeared to be protective. Now let's move from predictors of PSAs to a study that explored where PSA first manifests, especially whether clinical symptoms appear in sites previously affected by subclinical inflammation. This study investigated whether the first clinical manifestation of PSA appear in anatomical sites previously affected by subclinical inflammation, using data from the Rhapsody and the SOAR cohorts. Psoriasis patients underwent baseline clinical and ultrasound assessment. Among those who later developed PSA, researchers examined whether the sites of symptoms onset, like joints, entheses, or tendons, had shown tenderness and sonographic abnormalities at baseline. Out of 226 patients, as 150 initially presented with subclinical PSA, and a total of 31 patients actually developed PSA during the follow-up. Most of them were from the subclinical group. Only 28 were included in the final analysis. And a notable finding was that 19 of those 28 patients developed PSA at sites that already show signs of subclinical inflammation at the baseline. Among the 14 patients with sonographic abnormalities, 13 had joint involvement, most commonly on the small joints or the wrist, followed by knee and metatarsophalangeal joints. These findings not only support the idea that PSA often emerge in sites previously affected by subclinical inflammation, but also reinforce the value of musculoskeletal ultrasound in detecting PSA at its earliest stage, and the persistence of inflammation in joints that later become clinically involved suggests that many cases of subclinical PSA may in fact represent a very early PSA. The next study examined clinical and genetic factors linked to acute dactylitis in PSA, using a prospective cohort of 1,216 PSA patients, followed over 12 years. Over half, around 52% of them, experience at least one episode of acute tender dactylitis. Regarding the baseline characteristics, 57% of the patients were male. HLA-B27 was present in 16.6% of the cohort, and HLA-B38C12 haplotype was present in 10.9% of the patients. They use adjusted models to identify factors linked to dactylitis, not just the onset, but also the time for resolution. And they use also sensitive analysis based on HLA haplotypes. What did they found? They found that the risk of dactylitis increased with male sex, higher body mass index, and the use of NSAIDs, and decrease with older age, longer PSA duration, and the use of biologic or targeted synthetic DMARDs, which also shortened the symptoms duration. Regarding to the genetic markers, HLA-B27 and HLA-C12 were positively associated with dactylitis, while HLA-B51 appeared to be protective. In sensitive analysis, the haplotype HLA-B38C12 and the HLA-B27C02 were significantly associated with increased risk, with an odds ratio of 1.5 and 1.6 respectively. However, neither individual HLA alleles nor haplotypes either were independently associated with time to symptom resolution, in contrast to the protective effect seen in the advanced therapies. These findings suggest a genetic predisposition to acute dactylitis and support early intervention with advanced therapies in patients at a higher risk. Actual PSA was also a key focus at this EULAR. This poster analyzed sacroiliac joint involvement via MRI, X-rays, and clinical data from 581 PSA patients. Among those, 373 were classified as clinical PSA, while 208 were classified as XSPA plus psoriasis. They were mostly biologic naive, over 70% of them at the time of getting the image, with a mean age of 45 years old, and they were 47% male. What did they found? They found that 31% of them showed sacroiliac joint inflammation on the MRIs, consistent with actual SPA. 21% had inflammatory lesions, 28% had structural changes, and 76% of these had both inflammatory and structural lesions. 35% of MRIs were normal, no ESPA and no differential diagnosis, but others MRIs reveal non-SPA conditions like osteitis condensans ili, 8%, probably a strain-related bone marrow edema, and osteoarthritis. And among the 259 patients with X-rays, 29% of them met the modified New York criteria for sacroiliac involvement, and this was predominantly bilateral, over 90% of them. About the clinical features, the patients with MRI axial PSA were more likely to be younger, male, HLA-B27 positive, and more likely to have nail psoriasis, uveitis, and inflammatory back pain. Surprisingly, best day score did not differ, highlighting the limitation of clinical indices in detecting actual disease. Although PSA was more frequently seen in men, women with MRI confirmed disease had more bone marrow edema and more sclerosis, and younger patients had more active inflammation, and older patients showed more ankylosis. Overall, this study underscores the added value of MRI in detecting actual PSA, where clinical signs may be subtle or misleading. Despite the advances treatment, we know some PSA patients remain in a state of persistent disease activity, and this study aimed to identify predictors of refractory PSA using real-world longitudinal data. Refractory PSA here was defined as persistent to moderate disease activity over 75% of the visits and failure to 3 or more DMARDs. One of them had to be a biologic DMARD, and they were followed up over 36 months. In contrast, treatment amenable PSA was defined to patients maintaining a low disease activity or remission with less than 2 DMARD trials over 36 months. When compared to treatment amenable PSA, refractory patients with PSA were more likely to be female, had a higher baseline, higher DAPSA, pain scores, and tender joint counts. And the multivariable analysis found that female sex, baseline pain, and tender joint count independently predicted refractory disease. They developed a risk matrix to help estimate the probability of refractory PSA using these three variables. And both pain and tender joint counts were grouped into clinically relevant ranges. And for any given combination of pain and tender joint counts, the probability of refractory disease was consistently higher in female patients compared to males. These findings highlight the importance of including patient-reported outcomes, particularly pain, in early risk assessment and monitoring. And notably, female sex emerged as an independent predictor of refractory PSA, even after adjusting for baseline pain and tender joint count. And finally, continuing with the theme of complex patients profiles, GRAPPA presented new definitions for difficult-to-treat psoriatic arthritis and complex-to-manage psoriatic arthritis. These were developed through a global multidisciplinary collaboration, including rheumatologists, dermatologists, patient partners, and young GRAPPA members, and refined via two-round Delphi process with a strong endorsement from the broader GRAPPA membership. Difficult to treat PSA is considered a distinct subset within the complex to manage PSA, and it's defined by the presence of persistent, objectively documented inflammation despite multiple therapeutic strategies, specifically failure to respond to 3 or more treatments with different mechanisms of action, including at least 2 biologic or targeted synthetic DMARDs. In contrast, complex to manage PSA encompass a broader spectrum of management challenge beyond biological non-response. This included comorbidities, chronic pain, treatment intolerance, complicated disease control, and affect overall quality of life. This definition aimed to improve patient stratification in clinical practice, support clinical trial design, and guide personalized treatment approach. And importantly, these categories are dynamic. Patients may shift in and out difficult to treat or complex to manage states over time, depending on treatment response and evolving clinical factors. Thank you so much for listening. It's been a pleasure to share these exciting updates from GRAPPA with you today.
Yes, thank you so much, Dani, for presenting the clinical topics so brilliantly, and also to you, Kurt, to supervising and supporting Dani in presenting and preparation. So, Kurt, what is your perspective? Any add-ons that you want to share with us?
So first of all, I want to thank Daniela for the tremendous work she did. Maybe people should be aware that she has no academic affiliation, and all her, let's say, commitment to GRAPPA and to science is done in her spare time. So that's really very well appreciated and very courageous to do this. And of course, from the clinical perspective, there are many things to discuss. And the last couple of years, there was a high focus on comorbidities, and we all now realize that comorbidities are very important. Still, we know also the impact of comorbidities in this disease, but as we see that many more clinical aspects are highlighted, she made, in fact, a selection of a couple of topics which are very hot topics for the moment. And of course, we are very curious that if there are clinical indicators in combination with, let's say, biological indicators, and in the later stage with true biomarkers, to predict which patients with psoriasis will evolve to full psoriatic arthritis. And I think the studies she highlighted, there are already some clinical indicators. I think we only should look more carefully to it and to follow them up, and sure we will find patients because it's clear that most patients in the prodromal phase present with joint pain and tibial pain in combination with some others. And interestingly, in the study there were also some, let's say, exclusion markers which let's say make it less likely you will develop. So the HDL size, for example, the CW6, for example, the present were factors which decrease the risk. The second topic, which is very hot, and you're very familiar with it, Fabian, is the axial involvement. So there's, for a couple of years, there is a huge discussion ongoing if there is a true axial PSA, or do we have SPA with psoriasis? And I think the study she presented points rather towards the fact that there is a distinct form of axial PSA, and we're all familiar with the AXIS study, where data will be, let's say, coming out in the next couple of months and in the next year, which will help us to define the true characteristics of axial PSA. And thirdly, of course, the difficult to treat and the difficult to manage project is started now, and I think it's very important that we started to make some definitions about what is difficult to treat and difficult to manage, and to let's say clarify what kind of patients we meant to take in our programs to find solutions for this let's say for this problem, and especially to disentangle what features are really part of the disease or which features have nothing to do with the disease and not just an association with the disease. So yeah, a very great job, Danielle.
Yes, thank you, Kurt, as well. And also to you in the audience, please feel free and use the opportunity to address your questions to the experts that we have here in the room with us today. One comment from me to the actual PSA study, because I think it was only looking at the sacroiliac joints, and this is something that we have to be cautious when interpreting for actual PSA, because we know from different studies that roughly 20 to 25% have isolated spinal disease, which is frequent in actual PSA, which is different to the conundrum that we have with actual SPA. So I think only addressing the sacroiliac joints might fall a little short for actual PSA. This was just my comment about this specific study.
Yeah, for sure, I agree with this, but the problem is I think they simplified a bit the startup, because we all know that once we go up in the spine, we have another disease besides SPA, so the diffuse idiopathic skeletal hyperostosis, which will even more complicate more the let's say the distinction between the three different forms. So
I also agree with this, and I think this will be a really key point also coming from Access, not only the classification criteria, what is actual PSA, but also all the imaging data that has been acquired, and that will give us really relevant and useful results in the upcoming years. So really looking forward to this. And again, Chris, I would like to invite you to share your opinion, because I think especially for the clinical topics, the patient perspective is crucial. So what is your take on the presented abstracts?
I enjoyed the selection, Danielle. I thought it was very interesting, and I think for the patients understanding a little bit about it's such a multifaceted disease, and trying to understand how all the symptoms that the patient's experiencing, how that fits into, is it psoriatic arthritis or is it something else, right? Is it this part of this complexity of managing the disease is really important for patients to understand, as opposed to that being somewhat dismissive, right? Are my symptoms the disease, or are they something else? And how does that fit together is important for both the clinicians and the patients to be on the same page for managing and creating care pathways and being able to move forward. So the more we can understand about those complexities and how they fit with the diagnosis of psoriatic arthritis, helps the patient also be able to follow along and make sure they're doing the best that they can do to manage their disease. So it's all very informative for us.
I fully agree with this, because I think that in former times, patients with psoriasis and just joint pain, very often they were just classified as non-having psoriatic arthritis. Although now we understand that there is a prodromal phase where you can have, let's say, temporary swelling, which goes away, but then reappears after time. So I think I really would plead for a more thorough evaluation of those patients with just, let's say, clinical joint pain, we should do thorough examinations with ultrasound and eventually other imaging techniques, because it becomes more and more clear that a substantial number of patients have subclinical inflammation detected by imaging techniques, and that those are more prone, and let's say a consistent and large part of them within the next years will develop clinical arthritis.
And maybe I could also just hand over to you, Lourdes, because you, as a dermatologist, you also have the opportunity to already use deucravacitinib. So going back to the treatment topics, do you have any clinical experience using deucra in your PSO patients that we could benefit here as the room community? You're muted. Sorry, Lourdes, we cannot hear you.
Sorry for that. It's definitely being used, especially in those patients who prefer an oral type of medication, right? When you compare the efficacy compared to biologics, we know they do not get to certain PASI responses or IgA responses, but it really comes down to that shared decision making, right? Maybe a patient really prefers the mode of administration rather than achieving an X outcome that we are familiar with, but we do see a very good response, but not as a bimekizumab, right? So I think that there's definitely a place for these oral medications, and it's very, very valuable and exciting for many. And there are more coming into the market of this type of medications, right? As we've seen also through your other presentations. So I did have a question for you. I had my hand raised about the difficult to treat definitions. So this is perfect. So now that you've published, or you're going to be publishing, right, the definitions, what's the next step in terms of this project, right? Like, where are you heading now? How do you envision these being used in clinical trials, in clinical practice, the uptake from the community, and what are the efforts being put towards that?
Yes, thank you so much, Lourdes. I think it's really important, and this can only be the first step, that we speak about the same terminology. I think this is crucial for all upcoming research projects in this field. And we need to have quality indicators that really these definitions are now used, not only in clinical practice, but also in upcoming scientific and research projects. And I think it's really important that we first try to understand better how many patients are really fulfilling the different criteria. And this is something that most likely will be used in the upcoming and presented at the upcoming conferences, because this conference, we've seen a lot of the ACEs definitions being applied in real world data for axial spondyloarthritis, and I hope this will be the same with the GRAPPA definitions. Secondly, I think really important will be that we are better in differentiating the patients and the reasons for treatment non-response, because I think those patients really having active biological disease, they need to have a different treatment strategy than those that were having more chronic pain syndrome, no objective signs of inflammation. However, I think also those patients need to have different and new concepts, maybe more targeting the pain aspect, more multimodal physiotherapy interventions. There was also one study in AXPA that was really interesting, because it was assessing a digital tool where an app really improved patient well-being and bus die and bus fee. So I think this is something that we really should use as a starting point for future research projects in both populations, the complex to manage, but also the treatment refractory or difficult to treat patients that might differ from group to group. But I think this will be really important. And what I was mentioning in my presentation as well, I think this is only a starting point, and we will need to see how the criteria that we have proposed will now really play out in real life. And maybe they need to be modified in 2 or 3 years from now. So I think this will be important starting point, but definitely not will be the end. Kurt, I see your hand raised.
Yeah, I think it's really important what you just told, especially that second part, because classification criteria often leads just to labeling, and a label which, let's say, covers many different types of patients with many different phenotypes. So I think that's even the most important thing, I think, of this whole project, that in the second part we try to differentiate and make a kind of sub-classification, because there will not be one size fits all in this approach. at least in the therapeutic approach of these patients.
I think we're getting to the end. On behalf of GRAPPA and Young GRAPPA, we want to thank you all the presenters, all the attendees, the expert panelists for participating today, for sharing your time with us to make this a very successful virtual Congress highlights. Fabian?
Yes, I think there are two more important things that we have to mention. First, if you missed part of the episode today, you can go back and watch it on demand in a couple of days, available through the GRAPPA website. And especially because we are trying to have an interdisciplinary knowledge exchange, and maybe you are a dermatologist and enjoying the show here, what has been presented at the Rheumatological Conference. The next episode will cover highlights from EADV, where the hot topics from the psoriatic disease will be shared. And I will not be able to go to Paris to see those highlights, but I'm looking forward to the next episode that will be happening in October. So mark your calendars and watch out and stay tuned. So it will be on 1st of October. And yeah, really looking forward to seeing all of you there. And without any further ado, I think we
Maybe
can
just say thank you to Annie also, who has been behind the scenes making it all happen. So thank you, Annie, for your hard work and support.
Absolutely. And all the presenters and the senior GRAPPA members who were supporting them. And thank you, Lourdes, for moderating and guiding the whole event today. It was a real pleasure again for me. And yeah, we hope you enjoyed it as well. Stay tuned and hope to see you soon.
Bye, everyone. Thank you.
Thank you,
Bye.
everyone. Bye.
Bye, everyone.